Hi, everyone. My name is Samara Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada. And on behalf of MDC and NMD4C, the Neuromuscular Disease Network for Canada, I welcome you all to today's webinar. This is the second in our Hope on the Horizon series, which is a focus on clinical trials, treatments, and therapies, with this one particularly being focused on myotonic dystrophy. And this session today is made possible by restricted educational support by PepGen and Vertex, both of which have had no influence on today's content. We have three speakers lined up for today's session. Each of them will introduce themselves, but I again want to thank them that aside from research and clinical work, they've taken the time to prepare what will be really clear and well-delivered presentations on the topic. And with that, I'll pass it over to you, Dr. Kassardjian, to start us off. And I should mention that today's session is interpreted in French, and I will leave those instructions in the chat.
Thanks a lot, Homira. Okay, let me just share my screen here. Okay, perfect. You guys can see the screen, right? Everyone, that's good? Okay. So I'm Charles Kassardjian. I'm a neuromuscular neurologist in Toronto at St. Michael's Hospital. And I do have an interest in muscle diseases and genetic muscle diseases as well. And, given that myotonic dystrophy is a fairly common type of genetic muscle disease, we get a fair amount of referrals and consultations for this condition. So it's my pleasure. Thank you for inviting me to talk a little bit. I think I have the easiest job maybe of the night, which is to talk a little bit about basically the overview of the clinical features and a bit about the management. But given the timeline, it's going to be a very broad kind of overview. There's so much to this disease that won't be able to be kind of condensed in this very short presentation. Here are my disclosures. None are relevant to today's presentation. So we're going to do a bit of a clinical overview, including some management approaches and, what are the standards of care and current best practices that we employ for this condition. So what is myotonic dystrophy, just so that we're all kind of on the same page? And I think a lot of folks in the audience probably know this very well. If you're living with it or if you have family members with it, you probably know it better than the clinicians. But it is a type of muscular dystrophy, which means that it's a type of muscle disease that causes, it's a genetically based muscle disease that causes weakness through the destruction of muscle and replacement of that muscle with fat and connective tissue. And that leads to muscle weakness in a variety of muscles in a very kind of interesting pattern initially, and then the muscles can become more diffusely involved over time. The name myotonic dystrophy comes from the myotonia that exists in this condition and is one of the more characteristic features of this disease. Myotonia essentially means a delayed relaxation of the muscles. So if you're, for example, grabbing something, you might have a difficult time letting go of it because the muscles don't relax very well. And we'll talk a little bit more about that in just a second. And one of the important features of this disease, and up until now, we're going to hear more about, the hope for the future and the future treatments in the subsequent talks today. But up to this point, a lot of the treatments have been related to identifying and managing the systemic complications of the disease because it can affect multiple organ systems, with the heart and the respiratory system probably being the two that are the most impactful on a day-to-day basis, but it can affect other systems, as we'll see in just a minute. And there are two genetic forms that are recognized, that are called type 1 and type 2, that are a little bit different in how they present, but do share a lot of different features. And that's why they're kind of lumped under the, myotonic dystrophy categorization, even though they are different genetically identified. So what is myotonia? So myotonia is, as I mentioned, this impaired relaxation of the muscle. And many folks with this disease might recognize this idea of warm up, where you might get the myotonia when you initially try to activate a muscle, but then as you continue to activate it, the myotonia actually gets better. So patients will often describe this as a stiffness, for example, or a difficulty getting going. We'll hear that a lot, or letting go of things. So for example, when you first try to stand up, it might feel like your legs are stiff and you can't move, but as you do it a few times or as you take a couple of steps, it kind of loosens up a little bit. I just have this video here because sometimes, pictures are worth 1,000 words, and the myotonia that you experience, we look for clinically. And one of the ways we look for that is through what we call percussion myotonia. When we tap on a part of the body, we might get it. I'm just going to forward to the more relevant parts. This is a patient with type 1 myotonic dystrophy. And you can see when I tap on his forearm here, you can see how his fingers go up. And they don't just go up and then come right back down. They go up and they stay there before they very gradually go down. There you go, for example, there. And then you can see it quite readily in the thumb here as well. You can see how his thumb went up and then he kind of moved it because it's not super comfortable. He's trying to kind of loosen it up there a little bit. But that would be how one of the ways that we look for myotonia at the time that we're diagnosing people, for instance. Okay, so the systemic involvement is really crucial in this disease and is something that we, actively try to manage. Patients can have cognitive issues in some situations, and cognitive impairment. It can affect the brain in some patients, as well as daytime somnolence, which can be related to breathing issues, particularly sleep-related breathing issues. There are ocular manifestations, with cataracts being one of the more common ones, but some folks can have ptosis, which means drooping of the eyelids as well, that can be problematic. Can be endocrinological manifestations, and those can include difficulty conceiving, so infertility. Folks can develop impaired glucose tolerance or frank diabetes and thyroid dysfunction as well. And these things can have implications on your general health, so they're important to identify. Intestinal dysmotility can occur, so it can be hard for stuff to go down. People can have bloating or early satiety, which means it's hard to eat a lot because they feel kind of bloated, or it can get so bad that things actually become obstructed. And then, as I mentioned, the kind of more worrisome ones that we always look for are cardiac conduction defects. So this is the rhythm of the heart can be affected and lead to arrhythmias. And so this is something that we look for very carefully and co-manage with cardiology. There can be weakness of the respiratory muscles, and this can also lead to difficulty of breathing at nighttime, which then exacerbates, daytime sleepiness, for instance. And then more recently in the literature being recognized is there does seem to be an increased risk of various malignancies or cancers in patients with myotonic dystrophy. I'll get into that a little bit more afterwards, but this is something that we are kind of looking out for, and there's more literature, including just an article recently in the literature about this very topic. So just to talk about each disease a little bit. So myotonic dystrophy type 1 can present almost at any age, and there are severe forms, very, very young age, like congenital myotonic dystrophy, all the way up to late adulthood. And the weakness is what we call distal. This is the medical term for weakness further away, so in the hands and in the feet, rather than proximal, which is like at the shoulders and the hips. And so classically, the weakness is in flexion of the fingers, so grip, for instance. There can be weakness of the muscles of the face and weakness of the ankle muscles, so your foot can drop and you develop what we call a foot drop. Now, over time, the weakness can spread and affect many other muscles beyond this, but this is kind of the classic presentation initially. Individuals may also have evidence of that weakness of the face by having temporal wasting, and many individuals also have frontal balding. It can affect the muscles of the throat as well, so you can have sort of a nasal sort of speech, and because of that, also a difficulty with swallowing. Now, the most severe form is this congenital form, where essentially you're born with symptoms right away, as opposed to them developing at a later age. So infants can present with very poor muscle tone, weakness. This can affect the breathing quite prominently and swallowing, necessitating ICU admission at a very, very early point. And sometimes this is actually the way that the diagnosis is made in the parents, because the child is born without a known family history, for instance, and then it becomes to light, and then the family members are then checked for this condition, and they're identified at that point, and that's when, for example, I'll get a referral for one of the family members, for instance. Myotonic dystrophy type 2 usually presents at an older age, in adulthood, although some symptoms can start earlier. They're a little bit milder, they're not as prominent often, and so the diagnosis tends to be later and sometimes even missed. The weakness is more classically proximal, so in those hip and shoulder girdles, although the weakness can be in other areas too, but that's just the classic. And one of the more characteristic features of this condition that seems to be more absent in the type 1 form is this very prominent muscle pain, muscle aches, muscle pain. We sometimes use the word myalgia to describe that. That can be very prominent, very, very disabling for people, and also very hard to treat. The systemic features that we went through, how it affects all those different organ systems, does occur with the type 2 form, although it's less sort of stereotyped. It's sometimes less common, it might be more variable, or it might be less severe than in the type 1 form in general. But of course, everything varies for each individual. Here's the sort of genetic breakdown. So type 1 versus type 2, they're both autosomal dominant. What that means is, if you recall, you have two copies of every gene, basically one that you got from your mom, one that you got from your dad, sort of thing. And so with autosomal dominant diseases, you only need one bad gene. So even if one is good and one is bad, the bad one kind of overtakes the good one. And so in theory, anyone with these conditions would have a 50-50 chance of passing that bad gene to their offspring. And you can see they're different genes here, and they're caused by repeats. So in the DNA, there's these abnormal either three repeats, CTG for DM1, or four repeats, CCTG for DM2. Because of that repeat situation, DM1 has what's called anticipation, which is the idea that in subsequent generations, when you pass it on, the repeat length can get longer, and therefore the disease can get more severe sometimes in subsequent generations. And that's why you can get that congenital form, for instance. That does not seem to occur with the type 2 form, and so you don't really have that congenital form or the anticipation reported as reliably or really at all in the literature. I think Dr. Lochmüller is going to get into this much more, so I'm not going to steal his thunder. But the pathophysiology is very interesting, and this will, I think, lead into potential therapies. But what happens is this very long, lengthened part of the DNA, because of all those repeats, when it gets made into RNA, which, if you remember, that's the code that becomes protein eventually, because that's what DNA, eventually is going to code protein. Those RNA become very long, and they can kind of start to create these loops on themselves, and those loops kind of clump together. This is the theory. This is the RNA toxicity theory for the disease. So they tend to clump together, and they can start to interfere with other things that happen, splicing, which is a way that we put mRNAs together to form the final mRNA that's going to make a protein. If you interfere with that process in various different genes, you can explain sort of the multisystemic nature of this disease. If you interfere with a protein that's involved in heart function, you might get heart problems. If you interfere with a protein that's involved in muscle function, you might get weakness or myotonia. So it sort of is a nice explanation for why this disease can affect so many different organ systems, and it provides a potential for therapies. Okay, so how do we manage this disease? As of now, there is still no approved disease-modifying therapy, but again, I'm not going to steal anyone else's thunder. We're going to talk more about that after. So the management is what we would call supportive, or sometimes I use preventative. So we try to identify problems and we try to prevent further problems. And there are a variety of consensus-based recommendations. Dr. Gagnon's on several of them, I believe, actually, too. So you can see I just listed a couple of references here, but if you search this, there are numerous consensus-based recommendations available. And they really break this down into those multisystemic issues, the respiratory, the cardiac, exercise and physio issues, ocular, GI, endocrinological, psychological, which is sometimes neglected, the malignancy and cancer issues, and then other important issues as well. At least that's the way I've broken them down, but all of the recommendations have some comments on these different areas. So just in brief, and again, there's no time to get into each of these, could be an hour probably in of themselves, but in terms of the respiratory issues, we try to be proactive with this by doing pulmonary function testing, and if necessary, if there are any issues, referral to a pulmonary expert like a respirologist. As part of this, I always consider a sleep study as well, because many individuals with these conditions can have sleep disordered breathing or sleep apnea, and that contributes to their excessive daytime sleepiness. And a really important part of this is to try to prevent infections of the lungs. So getting all the appropriate age-appropriate vaccines like pneumococcal vaccines, but also annual flu vaccines, really, really important. So not something to be downplayed. In terms of cardiac, rhythm issues are really the biggest concern. And so doing some sort of rhythm monitoring on a regular basis, whether it's a simple ECG or a more prolonged rhythm monitoring like a Holter monitor, is recommended, usually annually if we can. An echocardiogram is more of a structural look at the heart. And then very low threshold for patients to be seen by a cardiologist or followed on an ongoing basis by a cardiologist. And this is also an opportunity to address cardiovascular health in general, whether that's through healthy diet and exercise. To segue into exercise then, so physical, this is actually a question that probably in clinic we get, but one of the more common questions is related to exercise. Unfortunately, there isn't really a one-size-fits-all answer, and different people will do different things. I don't think there's any strong evidence base for this, but generally speaking, the recommendation for most of these, first of all, is doing something is better than doing nothing. So you don't want to be sedentary. The exercise we often recommend is more moderate with some cardiovascular elements, walking, biking, whatever you're able to do, with more core and isometric exercises. So yoga, Pilates, elastic bands, body weight type of exercises rather than very heavy weights. Again, this is not a one size fits all, and it's not based on a huge amount of, data. But the concern, of course, is muscle damage that can be irreversible if you, overexert the muscles. Occupational therapy also as needed. And I threw in myotonia, the treatment for myotonia, that delayed relaxation. There are some medications that can help the muscles relax. Mexiletine is one of those. But unfortunately, many of these medications, including mexiletine, can have some cardiac problems. And so when you kind of weigh the pros and cons, depending on how bad the myotonia is, I find that many patients err on the side of not wanting treatment for this specifically. Annual eye exams to rule out to evaluate for cataracts and cataract surgery when needed, and some patients might need surgery to lift their eyelids as well. Poor intestinal motility can be very problematic for some people, and a high fiber diet is an important part of that. Good water intake and nutritional intake, SLP assessments for swallowing, and then a low threshold again for a GI referral if needed for some advice on how to manage some of these issues. I think one of the key points here is that this is a multidisciplinary disease, and so it's best managed in a multidisciplinary fashion. Endocrinologically, we try to test for diabetes on a regular basis. We do test for thyroid function as well, and lipid testing every few years also with fertility counseling. And then that's also an opportunity for cardiovascular lifestyle modifications. Sorry about that. The psychological aspects are sometimes a little bit overlooked. And so, some patients do have genuine cognitive issues and might need referral to cognitive neurology or psychiatrists as needed. And supporting care counseling, this is all part of it and something that we try to address, although I have to say probably not something we do a fantastic job of in a, rushed clinical environment. Now, I'm alluded to the cancer issue. So there is some data for increased risk of cancer in patients with myotonic dystrophy. And there does seem to be a little bit of a difference between the type 2 and the type 1 form. I've listed some of the cancers that are reported more in one form versus the other here in the talk. And you can see there's some differences, a little more, maybe lymphoma in type 2 and some of the other ones. I think this is evolving. And when you look at the literature on this, sometimes the type of cancers listed are not the same in the different articles because this is an evolving literature. And because it's something that's relatively recent, the recommendation is really for age-appropriate cancer screening, no additional screening. But I would say that having a low threshold to investigate any symptoms that are concerning, like, unexplained weight loss or bleeding that's unexplained, anything like that, having a low threshold to investigate those. And then in the other category, and this isn't meant to lower their importance, but surgery, there are certain medications that we try to avoid. We always alert the anesthesiologist and surgeons to this problem, including the need for additional monitoring. And I suggest my patients get like a medical alert bracelet or the equivalent of that in case they are not able to communicate this issue to a healthcare provider. There are many issues related to pregnancy and delivery, and there might be increased risks of requiring C-sections or delivery problems. Although I will say that many of my patients who have either of these conditions who have had to deliver, it's been okay, and we usually get them to have a high risk OB in those situations. And then, of course, genetic counseling, because there are options there now for in vitro fertilization and other issues like that. So many people are seeking those options these days. So I want to leave time for the other discussions. So in summary, this is a multisystemic disease, and so we address it in a multisystemic fashion and try to involve other specialists when needed because those extramuscular manifestations are important. And right now, at least, the management is more supportive and preventative. But hopefully, as we're going to hear, maybe that'll be changing in the future. And then, as Humira said, we'll take questions, at the end. So thanks a lot.
Wonderful. We'll ask Dr. Lochmüller to go ahead and share some information on trials. Over to you.
Yeah, good afternoon or good evening, everyone. I hope you can see my screen okay. All right, excellent. Thanks for confirming, Humira. So I'm based in Ottawa, and I practice both at the Children's Hospital and also at the Ottawa hospitals for adults, where I see patients with myotonic dystrophy. So I'll give you a bit of a perspective on the whole age range from kids to adults. And I want to talk about emerging therapies in myotonic dystrophy, which actually has become quite a big topic recently. And that's obviously something that we feel very enthusiastic and proud of, that there is something to talk about in terms of emerging therapies. So before I start, I should say that I'm an investigator in several clinical trials, and the ones that are relevant to myotonic dystrophies are highlighted in yellow here. So I'm not employed by any of these companies, and I'm not having shares. This is usually what I tell patients when I consent them to any of these trials. But some of the material that I'm showing to you today is related to these trials, or even information that these companies have shared with me. So as Dr. Kassardjian already explained, in myotonic dystrophy type 1, and I have to admit the majority of clinical research and trials currently is in myotonic dystrophy type 1, and that's also the most common in Canada. Is this particular CTG expansion that causes the disease and it's encoded on chromosome 19. And roughly there's a correlation of how long that repeat is and how early first symptoms present, and also how severe the symptoms are. So the lower repeats are usually related to a later onset and milder symptoms, and they are in the low hundreds, and that goes up then to repeats that are more than 1,000, that are then related to the severe congenital disease, where kids at birth already have breathing difficulties or feeding difficulties and may die early on. So what's been done so far, I think a few years ago my talk would have been fairly short, because there wasn't that much in terms of clinical trials and new drugs to talk about. One thing that I want to highlight, and this is what Dr. Kassardjian already said, we do know, and this is based on a clinical trial, that exercise, so moving your muscle, is actually good for the muscle. And it's still currently one of the key recommendations that do regular exercise. This is definitely be good for your muscle. So this is actually shown in a randomized large trial back in Europe called Optimistic. There's a lot of work going on. There was a small trial in France that showed that metformin, a diabetes drug, may have some benefit. And there is another trial that's been completed that particularly looked at the daytime sleepiness. But what I'm going to talk about are the newer things that are currently in trials, so that are not completed yet. So all what I say is still a bit of a moving target here. But one emerging theme really is what we call antisense oligonucleotides, or ASOs, with several different companies. And that has emerged from experimentation in animal models and in cell models, and I'll show a little bit of that, and has now gone into several phase 2 and phase 3 trials. And I will also touch upon, and I start with that, on a drug that has been specifically developed for the more severe form that affects children, the congenital myotonic dystrophy, which is called tideclosib, and is a so-called GSK3 beta inhibitor, and I will tell you what that is. The difference, just very simple to start with, of the ASOs and the tideclosib is ASO are given through intravenous infusions, so a drip every few weeks, while tideclosib is a medication that you can take through your mouth, and it's a daily medication. So what is this toxic CTG repeat that Dr. Kassardjian mentioned doing actually in the cell? So it builds these hairpins, and these hairpins are fairly stable structures within the cell, and you can actually stain them. So these little red dots in the middle of the screen on a cell nucleus, these are RNA inclusions where CTG repeats are found, and these dots are not present in normal cells or in cells from people that do not have myotonic dystrophy. And in addition to the RNA that's found there, the CTG repeat RNA, there are a number of proteins also that are trapped by the CTG RNA, so-called splicing factors like MBNL. And because these splicing factors are then no longer available to do the job that they're usually doing, which means processing other RNAs and making proper proteins, this is where many of the symptoms in myotonic dystrophy are explained now. So let's take an example, for instance, the chloride channel. So the chloride channel is a channel that sits on the muscle membrane. It has an RNA, and the RNA is made into the protein. So if the chloride channel is not properly processed because of this CTG repeat RNA and the trapping of the MBLL, then there's less chloride channel or less of the correct chloride channel being made, and therefore that causes myotonia. And similar sort of correlations have been made, even so that sort of missplicing does explain a lot. So that's why also the condition is also called a spliceopathy. It probably doesn't explain everything, but as a difference to some other muscle condition is not actually the lack of one particular protein. It's here is sort of the missplicing and the lack or the wrong function of many different proteins. And that in part explaining why people have so many different symptoms of the heart and the bowels and the muscle and the endocrine organs, etc., etc. So what does that one drug doing that I talk about first that was developed for the children? So it inhibits this particular enzyme, GSK3 beta, and that's actually increased in the muscle of patients with myotonic dystrophy. And if you bring it down, that has been shown in mice, then that actually helps the muscle. Secondly, also what it has shown, this drug also degrades some of the toxic CTG RNA. So therefore, that was put into a trial, first in a phase 2 trial that I'm not going to talk about, that was done in a group of young adults with congenital myotonic dystrophy back in the UK. And then in a phase 3 study, and the open label extension of that study is still currently ongoing. That was partly done here in Canada with sites in London, but also a site here in Ottawa at CHIO. And this study included kids from 6 to 16 years of age. And for the first part of the study, some of the kids got the real drug and the other half got the placebo, a dummy medicine. So these are sort of these so-called double-blind placebo-controlled trials whereby we really want to find out what is the drug doing, and neither the patient or the family nor the investigator know actually who's getting what until the study is completed and everybody gets unblinded and the data gets analyzed. So this is sort of the highest level of evidence that is required for drugs to actually make the regulatory approval possible afterwards. So this was a 52-week long study, and a variety of outcome measures were captured, and Dr. Gagnon will tell you a little bit more about outcome measures. But only very briefly here, there was a special scale developed because there are so many different symptoms in kids with congenital myotonic dystrophy, so that it was felt no single measure alone would sort of give the full picture. And this scale was specifically developed together with the FDA. And then there were a number of so-called secondary outcome measures, and I will come to them. So we have the result, and this is known for about 2 years now. And this primary endpoint, that scale, that was specifically developed actually did not show a statistically significant difference between the two groups. And that was a bit disappointing, of course, because this is the endpoint that people look at first, and that usually is the one that then is a go or no go for regulatory authorities such as the FDA or Health Canada for Canadians. And the reason why this scale didn't show a difference was because not only the patients on the drug got better, also the patients on the placebo got better. So there was a fairly large placebo effect. And in a way, that also justifies why there needs to be a placebo. So you can't just give someone a drug and say, oh, probably they're getting better. And they will get better, possibly, but you don't know whether it's actually the drug that's doing the job. So in this case, there was a large placebo effect. However, what was more encouraging is that in several of the other outcome measures, and they ranged from a 10-meter walk and run test, so where it was checked how quickly kids can walk or run, muscle strength, as well as cognitive tests, the kids improved, and they improved statistically significant for the drug as compared to the placebo. So there was a signal basically that the drug is doing something that was not expected and that was not seen in the placebo group. And this is a complicated scheme, but this just shows the two groups of kids, number 1 to 23 and 24 to 46, for some of these outcome measures. And just if you look at the color scheme, so everything that's purple shows improvement, everything that's gray shows no change, and everything that's green shows decline. So on the right side are the kids that got the tideglosib, the drug. On the left side are the kids that got the placebo. So on first side, you will see there's more purple on the right than on the left. But what you also see is that some of the kids improved over several domains, but these domains aren't always the same for each kid, right? So that the response for some was more seen in the walking, some more for the cognitive, etc. And one thing that did actually improve for many of the children, which was not captured as an endpoint, rather as a side effect, was the bowel function. So a lot of the kids had less problems with their bowels. So the open label study is still ongoing. So an open label study is usually following a double-blind trial where everybody is moved over to the drug, so no one anymore receives a placebo. And that also means that the efficacy endpoints are less important at that time, but the safety is being looked at. And this is now going on for more than 3 years. The majority of children is still on the drug, and the drug has a very good safety profile. So there weren't any sort of worrisome side effects that have been observed. The study is still open also actually to accept additional children with a childhood onset myotonic dystrophy and also some adults. The company is currently in negotiations with regulatory authorities, particularly with FDA, what the next step should be to get this drug approved. So we'll watch for that. And that's the summary which I basically told you about. And I move on to the other group of drugs, and these are the so-called antisense oligonucleotides. And I start with one of these drugs, which is the one that Kassardjian has developed, but they basically all do pretty much the same thing. And that means they have a sequence that's complementary to the CTG repeat. So they latch on to the CTG repeat RNA and basically both take that CTG repeat out of business, but also release those splicing factors that are trapped. And in theory, that should not only help the muscle, that should help all the other organs where this type of drug gets to. So if you have an intravenous infusion, it should get into pretty much all of the organs in the body, also to a different extent. And these drugs, antisense oligonucleotides, are already available for several years. So And in fact, one of the drugs in spinal muscular atrophy is an antisense oligonucleotide. So question is, why haven't we trialed this much earlier in myotonic dystrophy? Well, the reason is that a muscle is actually not very easy to penetrate by an antisense oligonucleotide. There was early work where people have just tried so-called naked antisense oligonucleotides, and very little ended up in the muscle. So it wouldn't have had any positive effect for the muscle in myotonic dystrophy. And the trick that PepGen and several of these other companies that I will mention have developed is to bind another molecule to the ASO that helps it to get across the muscle membrane. And that's depicted here. And this is from a tissue culture experiment. So there are muscle cells in a dish from a patient with myotonic dystrophy, and the cell nuclei are in blue, and that's where you want to get your antisense oligonucleotide to. And the antisense oligonucleotides, the ASOs, are labeled in red. So on the left side, there are ASOs that are the standard old style naked ASOs, and very little gets into the nucleus. While on the right side, this is an ASO that's coupled to a molecule that shuffles it across the muscle cell membrane, a so-called cell penetrating peptide in this case. And there's a lot more red, meaning a lot more gets in. And that is also having an effect on the cell. So there's less of these trapped muscle-blind molecules, less foci, and also the splicing in these muscle cells get corrected. So you might ask, well, this is nice to help some muscle cells in a dish, but what does that mean for patients? And therefore, well, of course, there needs to be a clinical trial, and the first results of the phase 2 trial for just a single dose of this antisense oligonucleotide have recently been released, and I've presented them at the World Muscle Society in Vienna a couple months ago. So these were small numbers of patients still, in each group only 8 patients that got just a single shot intravenously of this antisense oligonucleotide. And then muscle biopsies were taken to see whether the ASOs got into the muscle, first of all, because that was the question, is the uptake better than with the traditional ones? And secondly, does it correct the splicing, which is the cause of many of the problems? And 3 different doses were trialed or were in the protocol for that. And what it showed was, first of all, it's a relatively safe therapy. Well, it was a single infusion only. And secondly, in the direct sort of correlation with the amount of antisense oligonucleotide, there was a correction of the splicing. So obviously with the placebo, there was no correction. With 5 milligrams per kilogram of the drug, 12%, with 10 milligrams per kilogram, 29%, and with 15 milligram per kilogram, 53% splicing correction in the muscle. So that is very encouraging in terms of actually getting the drug into the muscle, first of all, and secondly, then correcting the molecular problem. Well, does this make people better? Well, we don't know that yet. So that there have been measures taken, like measures for the myotonia and walking tests and all of that, but no one would really expect that a single dose of this medication would make a hell of a difference to patients. And the reason for that is twofold. First of all, of course, the drug get washed out from the body over time. So after a few weeks, basically all of it ended up in the toilet, so the urine, so the kidneys, they excrete the antisense oligonucleotides. So very little of it will be left in the muscle. And secondly, the cells will have built new antisense new CTG repeat RNA. So the problem is back, basically. So that has, of course, two relevant lessons here. First of all, antisense oligonucleotide need to be repeated every so often. And currently, the thinking is there would need to be an infusion every 4 to 6 weeks to keep the effect. And secondly, well, if something goes wrong, so if somebody reacts badly to the ASO infusion, well, after a few weeks, the problem is gone because the ASO is out of the body. So that it's also a safety consideration. So it's not like a gene therapy where you put in a virus and a new gene and you can't get it back, basically. So this is the take-home message from this particular drug. There's a similar drug being developed by another company, which is called Avidity. And they basically do pretty much the same thing. So they bind an ASO to a molecule, in this case to an antibody, and the antibody is directed against the transferrin receptor. The transferrin receptor is expressed on muscle cells on the surface, and therefore, if that antibody latches onto the receptor, it carries the ASO into the cell. So basically, just another trick to shovel the ASO into muscle, which otherwise wouldn't get in. So they show similar results. They have splicing correction and they have muscle blind release once they give single doses of this drug. But what they have done as well in their phase 2 ARENA trial, and these results have been released a little while ago, is that with several doses of the drug in increasing doses, they get improvement at least of some clinical measures. And the one that seems to be reacting fairly quickly is what's called the hand opening time. And basically, hand opening time means a measure of myotonia, meaning there is a video that sort of captures how quickly somebody can open their hand. It's as easy as that. And that seems to be responding fairly well and dose dependent to this treatment. And this is a video of it. So on the left side, obviously, this is before treatment where there's fairly strong myotonia, so a long hand opening time. On the right side, there's after the treatment, after the third dose, where the same individual can open their hand much more easily. So that's obviously an impressive video. And on the other hand, what we, of course, want to see is not only an improved hand opening time, because the same effect we can get with just giving people maxilitine, the drug that Dr. Kassardjian already mentioned, right? So a drug that only improves myotonia, well, it's nice, but obviously we want to see drugs that improve not only myotonia, but many or all of the other symptoms, particularly the muscle weakness and the heart problems and the bowel problems, etc., etc. So these drugs potentially could do that, but it still needs to be proven. And that's why there's now a larger phase 3 trial going on called Harbor. And that is fully recruited now. It's ongoing, and results will become available by next summer. So some take-home messages here, and I'm unable because of the time to talk about all the trials, but I hope I mentioned the most relevant ones that are running here in Canada. There's quite a few more, and some are in preclinical development. But what I want to convey is that every clinical trial that provides an answer to the research question is a success. Because that helps us to find out what's working and what's not working, and what method and what measure we need to do, etc. So evidently, there will always be some clinical trials that do not show improvement in the patients, and this is disappointing. But on the other hand, they give us very valuable information to actually find out about better treatments. Participation in clinical research is essential. It doesn't necessarily need to be a clinical trial with a drug for everyone. If it's a registry, if it's a biomarker study, any such sort of information that you can provide and that you volunteer for research is important and gets us closer to these treatments. And the choice of outcome measures, and Dr. Gagnon will talk a bit about that, is really critical to find out. And we do learn in these first clinical trials for myotonic dystrophy what the right outcome measures would be. So several companies ran phase 2 and phase 3 trials with the hope for approvals by regulatory agencies in the next 2 to 3 years. And one important thing also to remember, in Canada, Health Canada is the regulatory agency, not the FDA. So if you hear somewhere on the internet something has been approved, always double check. Does that mean, is it the FDA in the US, or is it actually Health Canada in Canada? And it could be different in terms of what exactly has been approved and also at what time. And I thank you all for your attention. And that's from the Rideau Canal last January when we were out skating. Thanks so much.
Thank you very much. We'll go ahead and call on Dr. Gagnon to talk about some of the outcome measures you began to share and how we can measure a good response when it comes to new treatments. And I'll pass it over to you, Dr. Gagnon. That looks great. Thank you.
Great. Okay, great. So thank you for to have invited me. My name is Cynthia Gagnon. I'm an occupational therapist by background. I'm a professor at University of Sherbrooke, but in Saguenay-Lac-Saint-Jean, where there's the highest prevalence of myotonic dystrophy in the world. And my interest in research is really about the natural history study that we'll talk a little bit, and the selection of outcome measure to assess intervention efficacy. So I want to go back a little bit, and I'm glad that both previous speakers have set the ground for what I will be taking. But I think it's important to understand a little bit. We talked about clinical trial, but there's a whole path before we hear about clinical trial in human. So the first thing here is that we do need to understand the pathophysiology of the disease. So what is actually wrong in our cells, in the way it functions, what needs to be fixed. And then it can lead to several different targets. So Dr. Lochmüller talked about ASO and other, we can talk about gene editing, different options that you've seen maybe in DM1 or in other disease. But it really depends on where you're going to act to fix the problem. So that will lead to different type of drug that could be used. And that's important further down, and I'll explain to it. Then the important thing is that and that's just a general rule, from a 10,000 potential candidate that you try in the lab within a cell or, an organism, then there's only probably 2 candidates that will be there for a phase 3 trial before you get the final approval, and then you can get access to that drug. So there's a lot of potential candidates that will be taken out. And Dr. Lochmüller is very used to that, but some of them will just be because they're not working. Then there's some that because they're too toxic. So if you take the drug, your body is not reacting very well, and it will be toxic to have it. So that's the 2 main problems at the cell level. Then you get the preclinical test, where you try it in a human, or not a human, but an animal model, different type of animal model. But the animal model, as you probably understand, or is different from a human model. So sometimes it's okay in an animal model, but when you come to the human model, then it becomes too toxic for the human model. So the animal model is what we call preclinical test. And then once we feel that it's it's working, it's showing some sign in the animal model. So it's the mouse is stronger, it runs faster, it's more alert, it's less fatigue. Then you move on to the human model, which is the phase one. And the phase one is really, really just about, okay, how much do I need to give this medication? Is that 1 milligram, 4 milligram? Is it twice a day? Is it once a month? So this is the type of question you're starting to answer in the phase one study. The other thing you're trying to figure out is that is the drug is actually going to the muscle. And Dr. Lochmüller has alluded that, okay, so the ASO, the naked ASO, wasn't reaching the muscle. Because when you try it in a cell in the lab, there's nothing else. But when you get it into the body, sometimes it's disintegrated by the stomach, or the intestine. It doesn't go to where it should be going. So there's all sorts of things that you're looking at in the phase one. And there's very few people that's going to be in the phase one, because if it's toxic or it's not working, you don't want to have 100 people involved in the phase one. So sometimes as a patient, you don't understand why I haven't been called. Why is it that I'm not selected? Why so few patients? Well, it's because of safety. And it's to make sure that we don't recruit 100 of patients and then we finally realize that it's toxic. So then we move to phase two. And the phase two trial that you've seen some of the drug that Dr. Lochmüller, it's really more into, okay, we're starting to see if it's efficacious. Okay, is that actually improving myotonia, improving strength, improving sleepiness? But then you're still in a smaller patient population. And then at the end, you go to phase three, which is usually thought to be the last step before you get your approval or not from the regulatory agency, either Health Canada, FDA, or in Europe, EMA. And so that's where you will have a larger number of patients, oftentimes in rare disease, international, so not just the US or Canada or Europe. And then after that, you get the phase where you get the approval by the regulatory agency, Health Canada. But there's another step after that is, and we'll not be discussing it today, but is, okay, but is that going to be repaid by my health authority? So is that going to be repaid? And in Canada, we get different provinces, so different health system. So a drug could be accessible in Ontario, but not in Quebec, or in Ontario before and after in Quebec. So that it is a complex path before you get to the actual being able to access that drug. So that's the first thing I wanted to put back. So that's a table that is provided by the Myotonic Dystrophy Foundation, and I'll show the other that is available, that is updated every few months to know about what the different companies are in the DM1, DM2 field, and where they're at. Are they in phase one, phase two, phase three? We don't have yet approved, but hopefully we'll have approved one day. So they show the different phases, and they're regularly updated. And in Canada, we also have the clinical trial, which give a little bit of a different information. But if you want to know what is available in clinical trial, there's this NMD4C clinical trial database. Then, okay, so we're treating something, but what do we treat? And this is a very interesting, very busy slide, but I'll walk you through. So we've shown here preclinical phase 1, 2, 3 phase of the study. And here we see that some of the actual drug will be root cause of the disease. So they'll actually treat the what is broken in the cell that is not working well. But there's some other drug that will work on the symptoms. So they will not cure the disease, but they will decrease the gravity of the symptom or the progression of the symptom. So Dr. Lochmüller talked about the pitolisant study, which is a specific disease protocol that was helping with attention, hypersomnolence, and fatigue. And so what is important is that at one point, hopefully, we'll have different drug on the market that will treat probably root cause of the disease, but not all the systems. So one root cause of the disease could not cross our blood-brain barrier. So our brain is really well protected. So a lot of drugs don't cross to the brain, which is a good thing for many different reasons. But it's also that it will not work on the central nervous system of Dr. Kassardjian said, Charles has talked about the the CNS involvement, the cognition. So some of the drug will work on the motor, but not on the cognition. Some, and that's awful to pronounce, but tideglizib, the one that you talk, will work on, we may reach the CNS. So different type of drug could do different things. So that's also important. And one of the issue that will be very important, even when the drug are approved, is to understand, can we take one with another? Should we take this one first and this one second? When is but that's going to be an ideal world. Well, not there yet. We're hoping for a first, but we saw in other disease that can also become something that is important to understand, is the treatment plan. Then right now, we've seen that in the first speaker, it is a complex disease. And right now, there's some of the issues that are not touched upon or that are not the key aspect of the clinical trial. It may have an effect, but it's not the key things that are assessed in the clinical trial. So we talk about the muscle. There's a lot of them looking at the muscle. There's one that looks a little bit more, one or two that looks more at the cognitive function, and some of them will address the respiratory system because they work on the muscle, and the difficulty breathing in DM1 is mostly because of the weakness of your respiratory muscle. So it may have an impact on your respiratory system. But right now, there's no, and Dr. Lochmüller could tell after, but there's nothing specifically for gastrointestinal tract or cardiovascular system or the endocrine system. So there's still systems that are not yet assessed for clinical trial. Now, getting back to this, how do we as patient and as family can get involved while we are waiting for this to happen? So a phase 1, a phase 2, a phase 3. So this is one of my favorite slides that I show in most of my talk, which the Food and Drug Administration has done a roadmap to patient-focused outcome measurement in clinical trial. And I'll spend a little bit of time talking in this slide to understand what's happened before we get to the first human, So we're actually having a drug that works in animal model. We want to move it to human, but how do we do it? So the first thing is understanding the disease or the condition. And there's several steps into it. So let's take the idea of the muscle strength. So, okay, we know that DM1 affects muscle strength, but how fast does it affect muscle strength? Do you lose 1% per year in every muscle, in some muscle? Is everybody losing 1%, or is that different if you have a different phenotype of DM1, or you're older or younger? Because some of the drug will decrease the rate of progression of muscle strength. It will not stop it totally, but it will decrease it. But if we want to show that it decreases it, we need to know the rate of progression of that, muscle strength decrease. Then is that patient subpopulation? Does it work well in congenital myotonic dystrophy, in adult myotonic dystrophy? Does it work, equally in men and women? So all other question that needs to be known, and we need to know how severe the disease is. We also need to know what is the healthcare environment. What is the patient with myotonic dystrophy are receiving as care in the actual system? Because if you're talking about muscle strength and you've got some patient that receive 3 times of physiotherapy, muscular strength training, intervention, it's very different to give the drug to this person than to someone who is not actually training or having any physiotherapy intervention. And maybe the drug will not be as, you won't be able to see all the potential of the drug in one or the other population. And then you need to see the patient and caregiver perspective. So, okay, you have a drug. We talk about intravenous, administration. We talk about having it every month. We talk maybe about side effect. So what would be the appropriate or the acceptable way of having the drug? Often, if I have too much side effect, is that worth taking that drug? So that's other question that need to be addressed. And what we need to understand is what is important for the patient. So Dr. Lochmüller talked about myotonia, but myotonia is, okay, it's bothering, but it's not the main thing you probably want to see improve. And if the drug only improves myotonia, maybe that's not going to be so convincing to take it. But if it improves your strength, if it improves your ability to go see your friend, to keep your work, then that's very different. Then once we know what's important for the patient, we know our patient population, then we need to know, okay, so we've got this drug, but we need to have a primary endpoint, which means that there's something we're going to ask the patient to do, and this will mean that if it's improved in the clinical trial, then the drug will be approved. I make it a little simpler, but that's around it. And so this is very important, because if I say I improve muscle strength, that's not sufficient usually for the health agency, because if you improve by 5% your muscle strength, could you do more in your life? Is that worth? So they need to see how the patient feel and function. And function means walking faster, walking longer, having more energy, feeling less sleepy. So that's very different. And so we need to figure out which outcome measure could assess that. But if I want to assess that, I can assess, and you'll see different outcome measure in a minute. So that's where we have the conceptualizing treatment benefit and then selecting the proper outcome measures. Now, going back to my slide, when do we get involved as patient? All the way. So before we start even to think about, treatment, we need to understand the condition. So we need you to participate in what we call natural history study, where we will assess you every year, every 5 years, every 2 years in a specific protocol, where I will be able to say most of the patient lost around 1% of muscle strength per year, and it's faster in the distal muscle than the proximal muscle. So then when I plan the clinical trial, I have this information to give to the pharma company to be able for them to plan their clinical trial. Then I also need to see, if I assess you today and I assess you tomorrow, you should have about the same muscle strength, okay? So this is stable. But I also need to see if those outcome measures are good outcome measure. And that's a very complex topic, but we need to do that. So we may ask you to come one day, be assessed, and then come back 2 weeks later with the same assessment. But why? Because I need to show to the regulatory agency that the outcome measure is telling the truth. It's a true change. It's not just because it's easy to get better without the drug. It needs to be clear that this is it's like a blood sample. If you take a blood draw and you measure diabetes or glucose level, that's clear. That's an improvement. In neuromuscular disease, it's not that we need to improve. We need to improve your muscle strength per se, and then we need to improve the how fast you walk or something like that. And then after the drug is approved, it's not finished, because then we need to understand, okay, Mr. X takes drug A and Mrs. B take drug D. Is that similar? We have a lot of ASO. Are they working the same? Are they equivalent, or one is better than the other because they're packaged a little bit differently and they can access the muscle better? So we need also this to make informed decision and make sure you have the best treatment to your condition. So we still need to assess your condition. Now, how do we select those outcome measures? How do we select our endpoint? And in DM1, we're not short of potential symptoms. There's a lot of symptoms. Now, interestingly, what we discussed today was about the one that were the most important in DM1. So we talk about muscle weakness, daytime sleepiness for a pitolisant study, fatigue, myotonia, and then the muscle weakness will bring balance issue because you're weaker. So it's targeted towards some of the most prevalent and important outcome, impact on the patient. Now, how do we assess it? There's different way, and I'll just go very quickly, but there could be patient-reported outcomes, so PRO. So because of the drug, I improve my ability to see my friend, to lift heavy object, to achieve my day, and then you answer a questionnaire. Then there's going to be a performance outcome measure, and I'll come in a minute. So I will ask you to do something very specific, and I will then calculate a score so that I can see that before the trial and after the trial, you got better. Then there's clinician-reported outcome. Dr. Lochmüller talked in the congenital trial of an assessment done by the clinician in discussion with the parent and say, okay, is your children less sleepy? Is your children performing better, et cetera, et cetera? So it's a mix between an evaluation of the clinician and some information provided by the patient. And in some other disease, like let's say Alzheimer's disease, where the patient are not able truly to answer, then there could be someone else. Or in children, then the parent will be the proxy. So it's the observable reported outcome. So several things. We're going back to the trial you heard about with the avidity. And what they decide was to do a video and opening time. You saw that in a minute. They also look at your muscle strength, and they saw the impact on your activity of daily living. Are you able to cook? Are you able to get out of a car? Are you able to go grocery shopping? And now we'll see a little bit of the outcome measures. So let's say I assess muscle strength. Then there's different method. This is the very best method, okay? You're strapped all the way. It's very complex, but it's not feasible in a clinical trial because the apparatus take a lot of space. It's too expensive. It's difficult. And then your general practitioner or your general neurologist doesn't have that in his office. So when he wants to prescribe the drug, he will not be able to assess its effect. Then you got what usually you got your neurologist to do, which is a manual muscle testing. So we're just checking if your muscle are weaker or not, but that's not precise enough. So what you will probably be doing in a clinical trial is something with a dynamometer, which is a machine portable, and then will make you push against it, and then will record your strength. You will have an upper limb task. Like in some of the clinical trial that we talk, we have the 9-hole peg test. So it's peg that you put in holes and then you put it back and we time. So very simple task. We could ask you to walk, run, 25-meter walk, run. So you will be instructed to walk as fast as possible. So that's a function outcome. So your strength is more like, is what we want to improve, but we want to see the impact on your daily life, like walking faster. 30 seconds to stand. Then my last little bit will be about become a research participant. And I'll go very quickly on that. But just to say that we just recently did a strength training program among DM1 patients in the community. They had 5 exercises to do. What is interesting is they're very similar to a clinical trial. So T1, baseline, then we midterm, then 12 weeks later, we reassess, and we decide if we have an effect on the intervention. And then there was other things that we've looked at. And we've shown that we have improvement in strength, so the knee extensor, in the ability to go up and down. And we also take muscle biopsy, like what could happen in a clinical trial. It's not, but in some there is. And we've looked at actually what was happening at the pathophysiology. Was it fixing something? And it was actually fixing something even in the pathophysiological thing. And what is important is that that clinical trial of an intervention was a proof of concept and helped inform different pharmaceutical companies about this outcome measure is working very well. The other one, we've seen that it's not so good. And what is the patient were actually telling us that was improving because they improved their muscle strength. So that's a very good and important point. You can also talk about registry. So there's different registry because we need to know how many patients there is in Canada. because a pharmaceutical company will look at the market as well. If there's only 2 patients in the world, that's not as interesting as if there is 1,000 patients and we know where they are. So the registry, there's also the Canadian Neuromuscular Disease Registry. What will happen as well is we can call upon you, if you give your consent, to do different studies. So you can be called upon for natural history study, intervention study, or clinical trial. You can also become patient partner, and I've put the link here where we inform. We work in my research group, we work with 12 patient partners that inform every study that we do about what's important. How do we give back the message to patients? How should we do research? And the last thing, and I think that's very important, take care of your health while waiting for that therapy. Look upon to be vaccinated, to go to your art. As the more healthier you'll be, the more fit you'll be, and you'll get the more gain for those from those medication. And the other thing, just the last word, even if they're disease-modifying therapy, there will still need for rehabilitation. And that was a very good paper that is published in 2024. Even in SMA, there is different drug, and there's still a need for rehabilitation if you want to make the most of that drug. Because if a drug was improving by itself muscle strength, we will all be taking it because that will be less painful than going to the gym every week. So the idea is that rehabilitation will still be a need, and hopefully we'll come to a perfect disease-modifying therapy, but we're not there yet, and that's more difficult to think. And the other thing is that I just wanted to know, if you want to know more about what IDMC, what your disease is about, there will be the International Myotonic Dystrophy meeting in Saguenay in 2026, and there will be a patient day all in collaboration with Muscular Dystrophy Canada and Myotonic Dystrophy Foundation in Montreal. And there will also be one in Saguenay, and there's going to be also an online meeting for the people that doesn't have the ability to travel to either Montreal or Saguenay. Thank you.
Thanks very much, Dr. Gagnon. And I'm just inviting Dr. Kassardjian and Dr. Lochmüller because we'd love to get to a few questions that have been coming through. Before I get to the questions, I should just echo what many of you have already shared, which is we really appreciate Canadians who have been impacted by myotonic dystrophy and participating in these clinical trials. I think, Dr. Gagnon, you really spent the time in showing how much effort and resources is required, but also how courageous and bold families and patients are in engaging in clinical research, natural history, and clinical trial opportunities. So I'd love to go to the questions. One of the first questions is around, in the clinical trials, Dr. Lochmüller, are there indications so far that are there biomarkers that tell someone that they're a better responder? Particularly, this person's asking about CTG repeats. So is that something that's studied and looked at to see if there's a certain number of CTG repeats, and then do you do better on a drug or worse, or is that not something that is typically included in clinical trial protocols?
Yeah, so the CTG repeats, they are obviously relevant in many different ways. The first one is in terms of the inclusion criteria. So many of the trials would define a lower limit for when people can be included, and that's usually the 100 CTG repeat. So if you remember my and Dr. Kassardjian's slides, there are actually people with myotonic dystrophy that have between 50 and 100. So they also have myotonic dystrophy. And yeah, it's almost a bit unfair to exclude them. And there isn't actually a very good scientific reason why it needs to be exactly 100. I think the concern is that with someone who has between 50 and 100 CTG repeats, these could be people who only have mild symptoms or only get them late, and then it's difficult to see what is actually from myotonic dystrophy and maybe some other symptoms that are not related to it. But anyway, I'm sort of hoping that the group that has between 50 and 100 also gets included. On the other end of the spectrum, with the very high CTG repeats, so those patients are usually not excluded from the trials based on their CTG repeats, but based on their severity. So a lot of the antisense trials do not include patients that have the congenital form of myotonic dystrophy, unfortunately. And most of the trials do not include children, even the sort of childhood onset kid, except for the trial that was specific for congenital myotonic dystrophy. So there are these limitations. So the question is, does the CTG repeat then play a role as a readout, or do certain patients with a certain sort of number respond better to some of these therapies than others? So it's first question, it's usually not used as a readout because most of the drugs that we are currently using are not expected to change anything in terms of changing the number of repeats. There might be some drugs that are in preclinical development that look at either correcting the gene defect or at least the correcting the instability of the gene defect, and then that might become an interesting readout. So that's currently not being done. And whether people with shorter repeats or longer repeats do respond better or worse, that's not known at this point. So the information is captured, what sort of kind of repeat people have, but even the analysis usually is not stratified according to the repeat size. And to make the thing even a little bit more complicated here, so some people do not have the pure CTG repeat. They have so-called interrupted repeats, and they can have, which is then a lot of CTGs interrupted by maybe a few CAGs. And those people usually have less severe symptoms than the people with the pure CTG repeats, even if they have longer repeats. And we also don't know whether they respond in the same way. I would suspect if your antisense is specifically against CTG, well, there could be a difference, but we don't know that yet.
Thank you. This question's for you, Dr. Kassardjian. The individual is sharing that their daughter has myotonic dystrophy and has had cardiac follow-up, but nothing concerning. In that case, based on the clinical guidelines that you shared, is it still something that she should have yearly follow-up, or and she's just been referred to adult cardiology? She's 18, and the appointment that has been given is for late 2027.
Got it. Yeah, I mean, that's a good question. I think that it's a good idea to have annual ECG at the very minimum, because just because you don't have cardiac involvement now, you never know when it could develop. And so you're trying to catch it at the earliest possible point. Generally, if something were to develop on that annual ECG, for example, that might be a reason that the cardiologist would see you sooner than the appointment. And an ECG, you don't have to go to a cardiologist to get an ECG, or even a Holter monitor. A family doctor can easily arrange those things, or if you have a neurologist, for example, they might be able to order it. So I would still recommend annual screening, even if so far there hasn't been any cardiac involvement.
There was a question about myotonic dystrophy type 2. I know, Dr. Lochmüller, you mentioned that the vast majority of the clinical trials are focused on myotonic dystrophy type 1. So that is a common question that we have seen. Cynthia, Dr. Gagnon, the question is about strength training. And you had mentioned, you had included one of your recent studies around in women, but can you talk about strength training with weights? Has that been shown to be something that people with myotonic dystrophy can engage in? Is that important or safe?
Yeah. So we've done, and I've talked to it briefly, but I put into the PowerPoint actually the website where you can access it both in French and in English. So we've shown that the strength training was actually safe. And how we did it is that we actually took muscle biopsy, so very courageous patient, before and after a 12-week training. And we've been able to show that actually the muscle was more in shape after the muscle strength training than before. So, but it's important to know that before you engage, so activity, as we've said earlier, activity of any sort is good. You need to move, you need to do, biking, walking, whatever. If you do strength training, the only thing that we recommend, and we got the program with this, is that you consult with your treating physician to make sure that your cardiac or your respiratory system are in good shape to do that more intensive training. And there is also recommendation into how to engage in this. But if you do it properly, then it's safe. And it brings a lot of our patients, both men and women, have shown that they have more energy, less fatigue, decreased anxiety in women as well as improvement in strength training. So I think, and it was done at a local gym, so it was nothing fancy or complex. So yes, but it just needs that you have your treating physician to give you a go, no go on the other system that are affected by your strength training.
The other question is whether any of these treatments that you spoke about, Dr. Lochmüller, are studied in combination with one another. Because Dr. Gagnon mentioned that you likely won't just take the one treatment, let's say if approved and it's a successful candidate. Are there studies that are currently looking at combination?
So usually if you're on one experimental drug in a clinical trial, you're not allowed to be on another one at the same time because, well, then you don't know anymore what one drug does or the other, and maybe they even interact in some negative way. So that's usually not a possibility. In terms of the drugs that we usually prescribe for standards of care, like the Mexilidin that Dr. Kassardjian has mentioned. So that's depending on really on the protocol. Some protocols would allow to continue at the same level of that drug and then see whether the new medication has any additional benefit. Others would say, well, you need to come off that Mexilidin for a while until it's washed out of the system, and then we see the pure effect of that new medication.
The other question is around VX670. Is someone's participating in that and wondering what the results so far, or have there ever been readouts around that study so far?
Yeah, I think that's referring to the Vertex trial. So that's another antisense oligonucleotide, very similar to the two that I have presented. And in fact, we do this trial as well. It's a phase 2 trial. So it's with multiple dose at the moment in increasing dosage. And so far, there has not been any results released. All I can say, for those participants that participate in the trial in Ottawa, it looks like it's a relatively safe drug, very similar to the other ones. And in relation to efficacy, I think we can't tell anything at this point. Very similar to the other ones, right? I do obviously also show this video, and I appreciate the enthusiasm about it. But obviously, this is the video where it's probably responded the most, or one of the good responders, at least. Let's put it this way. Equally, I believe, even in the open label for some of these trials where people are on the drug or not on the placebo, you don't see such a big response. So there's certainly individual differences as well.
Thank you for sharing that. The other question that we have here is someone really saying that their children were diagnosed or now adults diagnosed at age 10 and 12 with, at that point, it sounds like myotonic dystrophy type 2. So I'm not sure if it was genetically tested or by clinical presentation. So they are asking about genetic testing. So I can follow up by saying we still have our no-cost genetic testing program through Muscular Dystrophy Canada. We can also support you to work with your neurologist on getting that genetic testing. So I'll follow up with that individual. The next question here is, a couple of years ago, someone has participated in a daytime sleepiness and myotonic dystrophy trial, but has since not received any information. And I know something that Dr. Gagnon mentioned about how important it is around sharing the results. And really, Dr. Lochmüller, you talked about every study is important in answering questions. Do either of you know the update on that daytime sleepiness myotonic trial?
So this refers probably to the pitolisant drug that a company called Harmony has brought forward. And they have released some top-line results, as they would call it, through press releases and some abstract, but it hasn't been published in full. So what I can say is probably it is effective in making people less sleepy, so it helps with the daytime sleepiness, as it actually been proven in another condition that has this extreme sleepiness called narcolepsy, for which it is approved actually. So, but they have not revealed how they move forward with this drug, whether they want to bring it to the regulators or whether they wanted to run another trial. So I have not had any updates since these sort of results were released, and that's as your participant is asking, it's probably like 2 years ago, so that's a bit concerning. I would agree.
Okay, just 2 more minutes left, so we'll take one more question, but all questions are noted and we'll follow up individually as well. Maybe this one is a quick one, which is how can I register for a clinical trial? Dr. Gagnon, you had shared the clinical trial database through the Neuromuscular Disease Network, and I will circulate that for everyone. Perhaps we can go to this question. Their son has congenital myotonic dystrophy type 1, 7 years old. Are there clinical trials currently for that sort of profile? Moves, alert, smart, and has seen improvements in physiotherapy.
Yeah, the only trial that's open for kids with the congenital form is the open label extension with AMO Pharma at the moment. So could contact us or Dr. Campbell in London if they are in the region.
Great. And I see one other question here, which is someone on Dr. Kassardjian. I wonder if you can look at this one here. I believe that the drug is modafinil to help stay awake, taking 2 in the morning, still getting bouts of extreme tiredness accompanied by extreme weakness at the same time that could last 5 minutes or 2 hours. Is this something consistent with type 2 myotonic dystrophy? Are there any trials to address this?
So I'm not aware of any specific trials, I mean, other than maybe some of the alertness medications. The issue really is that I wouldn't just assume anything about the etiology. The symptoms really should be addressed by your physicians to see that there isn't some other cause, whether it might be sleep apnea or anything else that might be treatable in other ways rather than simply the modafinil. So it's hard to answer that question just without a little more information. Fatigue, unfortunately, is a very common symptom for many individuals, and it can be very, very hard to treat, not just in myotonic dystrophy, but in a variety of conditions. And often it's a multifactorial issue, and you have to kind of address all the different issues to try to get at the source cause. So, treating one aspect of that fatigue might help with some of the symptoms, but, an exercise regime, good sleep habits, maybe addressing sleep apnea, good diets, what we call sleep hygiene, like don't use screens at night, like all these little things really do add up and help in those kinds of situations. But it's hard to know, specifically in this specific case.
And others in the comments are echoing what you're saying, Dr. Kassardjian, some relaying that use of BiPAP has also helped with that daytime sleepiness for some. So again, apologies if we haven't addressed every single question, but this is great. This is an opportunity. You can listen back to this session, see how you'd like to participate in clinical trials, in clinical research. And I just wanted to take a moment again to thank Dr. Kassardjian, Dr. Gagnon, and Dr. Lochmüller for really clear and well-delivered presentations. And just to leave on the note that Dr. Lochmüller mentioned, if you were presenting this a few years ago, you said it would be a much shorter talk. It is a time where there is new opportunities and new information. And with that, having opportunities like this is very important. So thank you all so much. And thank you to everyone who joined. I will follow up with the recording as well as questions that were not answered. Thanks, everyone.